So our next speaker is Dr. Paul Dworkin, who is the Executive Vice President for Community Child Health at Connecticut Children's Medical Center. He's also Professor Emeritus of Pediatrics at the University of Connecticut School of Medicine. He previously served as Physician-in-Chief at Connecticut Children's and Chair of Pediatrics at UConn.
Thank you very much, Barry.
Yep.
Thank you. Thank you very much, Dr. Good afternoon, everyone. I am so pleased and so honored to be here. My thanks to Barbara and to Wally, our program officer, and the JPB Foundation for the invitation to join this really remarkable cast of speakers today. And I am also so grateful to Ravi and to Brittany and to all who made this experience really so easy and so enjoyable. I also love the format that we were directed to use today. I have to stick reasonably close to the podium because it's being broadcast. But we were asked to give this talk in the style of a TED Talk, which frankly I much prefer. And I will admit that over recent years, I have become much more enamored with talks that feature storytelling as opposed to those that are more traditional for the august academic setting. But I've often felt that I needed to rationalize the approach that I was taking. And then I came upon a quote from a preeminent cognitive neuroscientist, whom some of you may be familiar with, Roger Schank, who sadly died just a few weeks ago, a professor emeritus from Northwestern. And here's the quote. No problem. Thank you. Here's the quote, if you haven't read it already. Humans are not ideally set up to understand logic. They are ideally set up to understand stories. So I'm going to tell you a story, and it's the story of our evolution and how we are engaging families and also communities. And it begins many decades ago with the recognition that it's important for us to engage families, whatever we specifically meant by that. And then we progress to recognize that it's really important for us to listen to families. And then we further progressed to recognize that we really needed to partner with families and with communities in all that we do, programs, services, and interventions. Currently, we are now recognizing the critical importance of elevating and attending to parents and families' priorities, opinions, and concerns in all that we do. And again, this is a story that has evolved over a number of years, and I'm going to attempt to share it with you in the brief time that I have today. So I've often described my career over more decades than I would care to admit as the relentless pursuit of the answer to the following question. How do we best transform child health services to promote children's optimal health, development, and well-being? Now, I'm a pediatrician, so you may think, well, I'm primarily concerned with treating diseases, disorders, delays. That's true. Or even preventing diseases, disorders, and delays. That is also true. But I would suggest to you that our highest, greatest opportunity lies in the extent to which we promote children's optimal healthy development. And this is not a stretch. In fact, this is intentionally a very old slide, courtesy of the American Academy of Pediatrics, that captures the mission of pediatrics. And if I were to slightly paraphrase, the mission is to promote children's optimal physical, mental, and social health and well-being. And this is very old. So, given our desire to promote children's optimal health, development, and well-being, how have we gone about this work? And I would suggest to you that we've gone about the work across three phases. The first, perhaps not surprisingly, because I and my colleagues were pediatricians at the time, We looked at the content of child health services. And when I say child health services, I mean well child care or child health supervision services, and asked the question, which content items are most amenable to strengthening to promote the best outcomes for children? The content of child health supervision services in general has not changed very much since, believe it or not, the middle of the last century. The specifics have changed. We have new procedures, we have new immunizations, but the general content is remarkably similar. And we believed that our best opportunities lie in looking at our developmentally oriented counseling, that is anticipatory guidance, and the way in which we performed early detection of children at risk for developmental delays and disorders, so-called developmental and behavioral monitoring in the parlance of the American Academy of Pediatrics. So the first study we did was to look at the value of enhancing anticipatory guidance through introducing to parents an understanding of relevant developmental themes. And I'll give you one example. At the 2-week visit, we would typically talk about feeding, sleeping, and elimination patterns. For the intervention group, we specifically incorporated discussion and dialogue on the predictable unpredictability of infant state organization, on the importance of bonding and attachment to discourage needless fears of spoiling, and the role of temperament or behavioral style, even at that young an age, to influence how the infant acts and reacts. This was a well-designed control study with sophisticated methodology, and our results revealed no difference between the intervention group and the control group. Frankly, despite my confidence in the methodology, we were hesitant to publish this study because we feared that it would be misinterpreted as stating that anticipatory guidance is not worthwhile. That's not what we studied. We looked at content. We ultimately did publish this in the journal Pediatrics, the Journal of the American Academy of Pediatrics. And here were the implications that we offered. Number one, anticipatory guidance should continue to be emphasized as a means to promote children's optimal development. Number two, we needed to individualize the content of our counseling at the level of parents' cognitive, cultural, and psychological readiness. And that was not our terminology. We took that from an article written in 1967 by Barbara Korsch, a preeminent pioneer leader from Los Angeles. 1967. We are still striving to catch up to wisdom that from the middle of the last century. And third, an open-ended, parent-led agenda may actually be preferable, which is an amazing preview to what we are now doing with Goal-Concordant care many, many years ago. So following our look at anticipatory guidance, we opted to take a critical look at so-called developmental and behavioral monitoring, and I had the opportunity to take sabbatical leave from UConn in Oxford. This is Tom Tower from Christ Church of the University of Oxford. I joined the British Joint Working Party on Child Health Surveillance, which was in the process of developing recommendations for child health supervision in the UK and the National Health Service. And the American Academy of Pediatrics was about to publish their latest recommendations for child health supervision services. So my intent was to compare and contrast. And I ultimately focused specifically on the issue of developmental and behavioral monitoring. The British favored a longitudinal approach called developmental surveillance, in which they would consistently elicit parents' opinions and concerns for their child's development and make skilled longitudinal observations. While in the US, the emphasis has been on administering developmental screening tools and the process of developmental screening to enable early detection. In our research, we looked at the extent to which the conditions that are targeted by developmental screening adhere to the well-established criteria by which conditions are judged amenable to the screening process. I'm not going to take the time to go through these individually, but I will say that the developmental conditions for which we are screening are not an ideal match for the criteria by which conditions are judged amenable to the screening process. These developmental conditions are different than cystic fibrosis or sickle cell disease or phenylketonuria or other inborn errors of metabolism. For example, detection and treatment during the asymptomatic stage must improve prognosis. Not necessarily true for developmental conditions. Similarly, we looked at the tests that are typically used to perform developmental screening and compared them to well-accepted criteria by which tests are judged appropriate for the screening process. And again, whether one looks at psychometric properties or other qualities, not an ideal match. Now, this doesn't lessen the importance of developmental screening, but it does suggest the context within which we must use and apply developmental screening. There was a third major issue that we also recognized from our research, and that is parents' appraisals. That is, parents' opinions and concerns are extraordinarily important indicators of children's developmental at-risk status, as well as children's developmental delays and disorders. And yet screening tests did not typically encompass the elicitation of parents' opinions and concerns. So on the basis of this, we advocated for an approach which we characterized as developmental surveillance and screening. That is, encouraging providers on a regular, ongoing basis to elicit and attend to parents' opinions and concerns, perform skilled longitudinal observations, take an informed developmental history, make accurate observations of children, and particularly when concerns arise, solicit input from others who know the child, a child care provider, a home visitor, for example, and to periodically administer screening tests to make sure that children do not slip through the cracks, but to always interpret the results of those screening tests, not in isolation according to a scoring metric, but rather in the context of all that we know about the family, the child, and the circumstances. Ultimately, developmental surveillance and screening became the official policy statement of the American Academy of Pediatrics and best practice as defined by clinical guidelines. So we felt good about the progress that we made with regard to early detection, but we appreciated that if all we're doing is detecting and we're not appropriately intervening or acting, then that certainly is not going to be very effective. And in fact, our colleague Ellen Perrin, a Boston-based developmental and behavioral pediatrician, also suggested that early detection without referral or intervention is unethical. And we agreed with this. So we had the opportunity to then consider, how do we put early detection in the appropriate context? And not coincidentally, this is what I would refer to as phase two, the 1990s, the so-called decade of the brain, in which the wealth of information, far better understood by those in this room than me, that was amassed during the 60s, the 70s, and the 80s, came to the fore in the 1990s in the popular press, cover story in Time magazine, as well as in the professional press, and this is the Institute of Medicine's From Neurons to Neighborhood, extremely influential work. I don't need to remind this audience of the extraordinary advances of our understanding in concepts of brain development. In fact, virtually all of these were referenced over the course of the day today. The extent to which brain growth disproportionately occurs prenatally and during earliest infancy. That neuroplasticity, while a lifelong trait, is particularly amenable to support and intervention during earliest childhood. That there are critical periods of development in which stimuli must be present. That Development occurs sequentially. Experiences must be sequential. Few infants will benefit from an algebra lesson. Few adolescents need to be held and rocked each day. And then the role of experience, which also was expounded upon today through multiple talks. Critically important concepts to influence our thinking about the role of early detection and the correct placement of early detection in the context of what we are attempting to do. Similarly, there are critical concepts in child development that came to the fore at exactly the same time. And the one that has profoundly influenced our work is the concept of developmental trajectories, advanced by our friend and colleague Neil Halfon, who directs the UCLA Center for Healthier Children, Families, and Communities. And what Halfon pointed out is that we could think about, or should think about, children as advancing along 3 developmental trajectories. There are those children who are progressing along a delayed disordered trajectory. These would be my patients as a developmental behavioral pediatrician, probably about 12 to 15% of the population, depending upon the specific jurisdiction of which we are speaking. And then the majority, although it's a slim majority of children, are progressing along a healthy trajectory. What we have not paid sufficient attention to in the past is a third critical subgroup of children who are progressing along a so-called vulnerable or at-risk trajectory. These are children who can go in one direction or another with positive, stimulating experiences. They can be elevated to a healthy trajectory. On the other hand, with adverse experiences, adverse social drivers, they can deteriorate to a delayed and disordered trajectory. And we've worked with the CDC, who has agreed that depending upon the specific jurisdiction of which we are speaking, this is 30 to 40% of children. It's a very significant subgroup of children. As you also heard this morning, there are also factors that can influence children's developmental trajectories, particularly those on an at-risk trajectory, in one or another direction. So you're well aware of the adverse impacts of socioeconomic disparities, lack of access to high-quality services, exposure to domestic violence. Unfortunately, there are so many drivers that have a deleterious effect. But fortunately, as you've also heard in the context of hope and positive experiences, there are many factors that can elevate a child's developmental trajectory, particularly important for those who are evolving along this vulnerable at-risk trajectory. The implications of this concept are also profound. And here's yet another example where we're attempting to catch up with wisdom from many decades ago. Here's a quote from Robert Chamberlain from 1992, and I can't improve on his wording, so I will share the quote with you. The most effective long-term strategy appears to be the development of a comprehensive, coordinated, community-wide approach focused on preventing low and medium-risk families from becoming high-risk, as well as, of course, providing intensive services to those who have already reached a high-risk status. 1992. So with this information in mind, we recognize that our previous conceptualization that we can promote children's optimal health development and well-being through a focus on child health services was misguided. And then at the very least, we needed to think more broadly about the interface among child health services, early care and education, child care, think Head Start, and family support, think home visiting as an example. With these concepts in mind, we were asked to take on the task in Hartford of answering the question, how do we best strengthen services in order to promote children's optimal health development and well-being? We had support from a local foundation in this work. All of you are undoubtedly familiar with Hartford. At the least, you've passed through it from Boston to New York or back. But for those of you who may not be as familiar, Connecticut is one of the wealthiest states in the country. We are consistently ranked among the top 4 or 5 with respect to per capita income. Hartford, the state capital, is consistently ranked among the poorest cities of its country, and in fact has been ranked the second poorest city of its size behind Brownsville, Texas. We are awash, unfortunately, in disparities, and Hartford has its lovely sections like Bushnell Park and has also a problem with unhealthy housing stock. So, with the challenge of figuring out what can we do, we engaged in a series of crucial community conversations with families and residents, with providers from different sectors, with city officials, with community-based organizations, with activists, and we were stunned by how quickly we came up to 4 common assumptions. And I invite you to think about the extent to which these assumptions may be relevant in the jurisdictions in which you are working and or living. Children with developmental and behavioral problems were eluding early detection. We knew that was true. Number 2, even in relatively resource-poor Hartford, there exists a wide array of program services that are available to support families and children and promote better outcomes. We knew there were gaps, we knew there were capacity issues, but there was quite a bit available. But there was a gap between the best efforts of child health and other providers and families to identify children for whom there are developmental concerns and the linkage of those children and their families to these community-based programs and services. So we hypothesized that Hartford's children and their families would benefit from a coordinated region-wide system of early detection and intervention for children at developmental and behavioral risk. And we devised a pilot study that included 4 core components that still constitute the Help Me Grow model today. Child health provider outreach to train child health providers in effective surveillance and screening, and to inform them as to the capacity of the model to link their children and families to community-based programs and services. Family and community outreach to encourage families to share their opinions, concerns, and priorities for their children, and to alert them to the opportunity to be linked to community-based programs and services. And similarly, the community-based programs and services needed to be engaged in the evolution of the model. Third, because we knew there were gaps and we knew there were capacity issues and we knew we'd need to be able to speak to impact for sustainability purposes, data collection and analysis. And then fourth, the really heart of Help Me Grow is a centralized access point that is telephone operators who are able to receive calls from families or from providers, discern families' needs, and successfully link them through care coordination to those community-based programs and services. The evolution of this model from a pilot in Hartford has proceeded far, far greater than we ever imagined. Our goal was statewide expansion. And the success of the pilot enabled us to do that in the earliest years of the new millennium. And Help Me Grow is still supported in the state budget as a program of our state's Office of Early Childhood. In 2005, we received a request from colleagues in Orange County, California, who felt they needed Help Me Grow, asked us to provide technical assistance. We did, and Help Me Grow Orange County today is one of our strongest affiliates. We then began to gain confidence in our ability to provide TA and began replication in 5 other states, and then ultimately received funding to develop our Help Me Grow National Center. Our executive director, Kimberly Martini-Carvel, is here with me today, and with support from the JPB Foundation and other resources, we now operate the Help Me Grow National Center at Connecticut Children's, and there are over 140 Help Me Grow systems in over 31 states and the District of Columbia. Far exceeded my wildest imagination. This is what the map looks like today. And fortunately, it is changing very rapidly in a positive direction. So you've already seen the content of this slide to introduce phase 3. Ravi shared another version of it, which actually I liked better. But it gets across the same point, and that is 80 to 90% of the drivers of the outcomes that we seek, promoting children's optimal health development and well-being, are driven by social, environmental, behavioral, and epigenetic factors. And we must keep these in mind if our goal is children's optimal health development and well-being. And in fact, our old misconception about the interface among three sectors has now been replaced by our flower diagram. Think dahlia, which has a lot of petals. And in this diagram, we have captured as many sectors as we can think of with whom we must engage if we're going to support families and promote the best outcomes for children. And you'll notice some of these petals are not yet labeled because we're not yet smart enough to recognize all the sectors with whom we must collaborate. And just to give you some quick sense of how we've operationalized this concept, our Office for Community Child Health at Connecticut Children's, of which Help Me Grow National Center is our signature program, has 17 community-oriented programs that engage with, touch upon, collaborate with all of the sectors in our flower diagram. So where do we go from here? And Bob Sege this morning referenced Goal-Concordant care, and this is the work that we are now doing in partnership with the JPB Foundation, and Wally has been an extremely important thought leader in the evolution of this concept, how we've operationalized it, and now how we are studying it. So we are looking at goal-concordant care and determining the extent to which it is an efficacious, strength-based approach to elicit parents' goals for their children's well-being that ensures that families drive the process of developmental promotion, early detection, and referral and linkage to programs and services. And we're doing this by studying the impact of advancing a focus on families' goals, priorities, and opinions, and bringing this concept to bear through both our developmental promotion activities, our early detection activities, and our referral and linkage activities through the Help Me Grow model. How will we determine success? Well, ultimately, it's the extent to which we will impact at the population level children's optimal health development and well-being. And we're committed to gathering that data, but it's complicated and it will take time. In the meanwhile, we need more proximate factors that can tell us whether we are on the right track or not and inform our continuous quality improvement. And our proximate factors are the extent to which we are strengthening families' protective factors, like a number that have already been mentioned today, like families' resiliency, concrete support in times of need, social connections, parenting skills, etc. And then also, as was also referenced today, if we are going to sustain this approach, we must be able to demonstrate its return on investment, cost savings, and cost benefit in order to ensure the long-term investment. So that is the work that we are doing now. One of the key lessons that we've learned, that all of you who are researchers have known for a long time, that the key to successful research begins with asking the right question. And for many years, the question that drove our work was, as I stated at the beginning, how do we best transform child health services to promote children's optimal health, development, and well-being? That was helpful, but it's not the right question. We now believe we have the right question. How do we best build comprehensive early childhood systems to strengthen families to promote children's optimal health, development, and well-being? We believe that a significant part of the answer is goal-concordant care. We are now investigating this and look forward to be able to share the findings with you. Thank you.
Thank you so much. Excellent work. And it reminds me of the CHICS program in New Hampshire that's just starting now. I don't know if you know that program, but the comprehensive, it's all in the right direction. Just wondering if the Pediatric Environmental Health Specialty Unit for Region 2 is a part of your care system.
Yeah, thank you. So, as I listened to your session, I realized that we have to go back to the flower diagram and make sure that we are calling out environmental health beyond the significant work that we are doing with housing. So we have a healthy housing initiative that is closely correlated with the Help Me Grow model. that addresses adverse influences in the home. It began as a lead abatement program, asbestos, and also mold and asthma triggers. And we've now expanded the conceptualization of that program to also include housing, sustainability, and security. But I'm mindful that even though we have been aware of what you shared with regard to the importance of green space and recreation, et cetera, I don't think we're calling that out sufficiently clearly in our model and in our partnership. So thank you for that. It's on my list of to-dos when we return.
Yes, one more.
Just a question about, I'm really happy that you talked about families, because I feel like that was such an important piece that was missing or just hasn't been addressed yet today. And I guess just given the mental health crisis that everyone's been talking about with young people, how do you foresee this model really benefiting families in the community when we see so many young people being hospitalized and at different levels of care and just having a real lack of support outside of individual therapy for children?
Yes.
How do we really amplify that for families, because that's where the sustainability comes from?
Yeah, absolutely. You know, I'll answer that in a couple of ways. We are in the midst of a crisis, and in my prior role, I was physician-in-chief, and I would walk through the emergency room and just be despondent with what I saw there, with the number of children who were stockpiled in behavioral health crisis. And the numbers then were so low compared to the numbers today. In fact, the numbers then are celebrated today, saying, look how much better we're doing. So it's such an urgent problem. So I'm mindful of that. However, and we must do whatever we can, and there are all sorts of strategies to try to mitigate the most appalling aspects of the problem. Yes. However, I firmly, and we believe that the only way to get a handle on the problem is to go upstream and to address this problem at its roots, which is to enhance families' capacities to promote their children's optimal health development and well-being through the variety of strategies that we know can be invoked. We are also involved in place-based work. We have a U.S. Department of Education Promised Neighborhoods grant. Some of you may be familiar with that, but it's an extraordinarily ambitious undertaking to create a cradle-to-career pipeline for particularly youth, but children of all ages, in just very poorly underserved areas. We're doing this in the 3 poorest neighborhoods in Hartford. Cradle-to-career is too late. Really, we need to be thinking about this at least perinatally, if not preconceptually. So I'm not offering this as a pie-in-the-sky theoretical answer, because I understand the acuity of the problem, but the only way that we're going to be able to get a handle on this problem and a downturn is if we start early. And somebody mentioned today meeting families where they are. That's been incredibly, incredibly important in this Promised Neighborhoods work, and it's also incredibly important in Help Me Grow, and it's really what is being manifest in Goal-Concordant care, with elevating families' priorities, opinions, and concerns as the most important driver of what we are doing. So it's such a compelling problem, and we need to do whatever we can at the moment, but we need to be thinking long-term, and it's hard to think long-term when you're in the midst of a disaster, which we are. But I think it's the only way that we will ultimately be able to get there. And I think part of the answer does lie in elevating families' priorities, opinions, and concerns to the highest level. And we're hearing from families in the most challenging of circumstances. They know what they need. They do know what they need. So thank you.
Thank you very much, Dr. Dworkin. Particularly for framing child development in this very important social, economic, and importantly political context. Thank you very much.
Thank
so
you.
We are supposed to come back at 3, but we'll look to Ravi for guidance on when we should be back.
Yeah, 3:10.
3:10. Okay. Thank you, Ravi.